nurse.
She's
okay.
sitting.
Well, no, I was just.
Oh, making
Oh,
sure
you're
she's still a
switched,
nurse.
yeah. Okay. Morning, everyone.
Good morning.
All right. So today I called this meeting because we're having some breakdown in teamwork and collaboration on our floor. And I've had some recent complaints related to pregnancy and patient care. This is going to be an open floor meeting, so everyone is welcome to voice their concerns and present information on our topic. Who would like to start?
I'd like to start just by stating that many of us nurses on the unit have had several different changes and additions to our workday because of the amount of pregnant women in not just our unit, the whole hospital. It seems like just as one example, last week I had a patient that was receiving ribavirin for RSV, and he wasn't even assigned to me, but I was in the middle of an admission and I had to administer the medication. I don't think it's fair that I have to add on to my workday just to please to meet the needs of the pregnant nurse.
Yeah, I do. I definitely understand your concern. And I agree that it's difficult to take on someone else's patients that aren't assigned to you, especially when we have our own responsibilities. But we have done some nursing research, and I found several articles that I'd like to share with you. One example is, according to Joyce Hood, her research shows that pregnant nurses should be reassigned if they have a patient with HIV being treated with pentamidine for prevention of pneumocystis carinii infections, RSV patients being treated with ribavirin, which you said you gave, or human parvovirus. In addition to ribavirin, chemotherapy is also another area of concern I found in research. According to research by Lawson, anti-neoplastic drug exposure was associated with a twofold risk of spontaneous abortion, particularly with spontaneous abortion before the 12th week. Anti-neoplastic drugs act on rapidly proliferating cells and therefore are of particular concern for a developing fetus.
So we all know these drugs can be harmful, but if we're using standard precautions, how does that not stop the risk?
Well, throughout my pregnancy, I've done a lot of research about it and stuff, and I found, according to research by Alex, that there are other routes of exposure, just besides just like handing a patient a chemo drug. I mean, you can get it intradermal, like absorption, from handling the drug and drug-contaminated materials. It also said here that inhalation from breathing contaminated air, accidental ingestion of contaminated food, or like hand-to-mouth contact, needle sticks. Also, like when we're doing IV tubing, like it can leak from the IV tubing or syringes onto like the skin or other workplace surfaces. And then chemo drugs are also were found like on patients themselves and their soiled linens. So even though we're following the standard precautions, I feel like according to the research, that we're still putting pregnant women at risk for spontaneous abortion due to these accidental exposures, even though we are trying.
Okay, I understand that, and I understand that precautions do need to be taken. If the patients aren't receiving those drugs, do we still need to switch our entire assignment? I was asked to switch with a pregnant nurse for their HIV positive patient.
Okay, well, I do have research here, and it is according to Gonzalez. The research states that in pregnancy, depending on the trimester, that exposure to torch infections, which include toxoplasmosis, other agents, rubella, cytomegalovirus, and herpes simplex, these threaten the fetal well-being and the pregnancy viability. So even though we personally have immunity and the moms have an immunity to these, the fetus is still developing, and these infections cross the placenta and can harm the developing fetus.
Well, I understand that, but it bothers me because when I was pregnant, I didn't receive any special, considerations, or I never was reassigned. I didn't feel good the majority of the time, but I still had to do my own job.
And I do understand that, and I'm really sorry that we unfortunately didn't make these accommodations earlier. Luckily though, our research has come a lot farther, and so we're showing things like we've talked about with the drugs and whatnot. Another developing research that I found was by Tia Talamancia that said heavy lifting and long periods of standing cause more negative outcomes such as spontaneous abortion, uterine contractions, preterm birth, and low birth weight infants. So the research is showing that in the past, it would have been better for your pregnancy to have some special standardized precautions to take. And I think we've covered a lot of really good issues today. I think these are some of the concerns that I've been hearing. There's a lot of important topics related to pregnancy and the workplace. Does anybody have any possible suggestions or thoughts on maybe how we could implement change so that we work more cohesively as a unit?
Well, I'm glad we had this meeting because now I have a better understanding of why pregnant nurses might need to be accommodated in the workplace. I feel comfortable working as a team, taking over, maybe handling these specific medications as long as the pregnant nurse is able to help me with some of my responsibilities as well.
Of course.
Okay. I really think that's a good starting place. I want to thank everyone for coming and giving your concerns to me. I'm going to take the information and the research that we've discussed today and take it to management and see if we can maybe implement some changes. I'm also going to make sure that we have copies of the research that are here in the break room. So if you have anything to add, go right ahead and we'll keep working through that.
Okay.
All right?
All right.
Have a good rest of your day.
Thanks, you too.
Do you guys wanna do that again, or should I give them back to her?